And so Dr. Jenny Sauk is a gastroenterologist from UCLA. Her interests include the brain-gut microbiome and the connection between stress-related IBD symptom flares, including a study of stress and disease flares in ulcerative colitis patients. She worked with Dr. Emran Meyer, who is a world-renowned GI and neuroscientist, an expert on the clinical and neurobiological aspects of how the digestive system and the nervous system interact in health and disease.
So anyway, thank you so much, Stacy, for inviting me, and I'm really getting excited to get to know your group. And so over the next couple of minutes, we'll be touching upon the brain-gut connection and the importance of this connection in IBD. And at the end of the talk, I'm hoping we have some time so we can brainstorm and discuss strategies that will help just so we could discuss how we could support our mental well-being and general health. So objectives, we're going to talk a little bit about stress and understand the physiological basis behind it. We'll talk about how mental health conditions affect IBD and explore how intestinal inflammation can affect our mental health, and then discuss potential future interventions that can address this brain-gut microbiome axis. So to get started, I just want to go over what is stress. So this was a question that was asked by a Hungarian endocrinologist over 80 years ago, Hans-Hugo Bruno Celje. So he asked this question. He's the father of stress research, and he was nominated for a Nobel Prize back in 1949 for his work in stress research. So he defined stress as the physiological adaptive response of an organism to adverse threats, which are endogenous or exogenous, psychological or physical, real or perceived. And so what he did in 1929 in a letter to Nature, he described a series of experiments on rats where he subjected them to different stressful situations. So he subjected them to cold, injections with various toxins, subjecting them to a lot of physical stress, physical exertion. And so what he noted was that despite whatever that shock was delivered, there was a similar set of symptoms that would occur shortly after. And so what he was trying to say was that just regardless of what that particular stimuli is, the general reaction to how our body reacts, it's to whatever it's considering a stressful situation is pretty much the same. So there are 3 phases to this reaction. So the first phase is called the alarm reaction. So this is when the body gets ready to fight and flight and mobilizes resources. Blood sugars go up, heart rate goes up, blood pressure can also go up, and this is considered our fight-flight response. And then the next phase is the resistance phase, and so this is when the parasympathetic nervous system kind of kicks in, and it tries to resist that impact of the stressful stimuli. So this is when the blood pressure, heart rate can start to normalize a little bit. And if the stressful stimuli is removed, the body can kind of go back to its normal state. But what happens is that if the stressor continues, or the perceived stress continues, the body still physiologically feels that it's under this fight-flight response. And then it enters the exhaustion phase where resources become depleted. And this paves the way towards chronic illness, anxiety, depression. So this stress response is evolved to really help. It's really helpful for animals in the short term, but it's not really very adaptive in the long term for us as humans. So Dr. Celje did feel, though, that we could manipulate our stress response. So what I find hopeful about this particular quote, that it's not the stress that kills us, but it's our reaction to it, is that in the face of a chronic stressor, like any chronic illness, we could develop techniques and strategies, yoga, mindfulness, deep breathing, that help us alter that physiological stress response. So we know that mental health conditions are important to address when we see the prevalence in IBD. So that prevalence of anxiety and depression is roughly between 11 to 40%. And if there's active disease, that could be the prevalence is higher in both conditions. So for both conditions. So I think it's important also to be thinking about post-traumatic stress disorder. In the literature, there's more about this now. The reported prevalence is about 19 to 32%, and it's more associated with Crohn's disease than with ulcerative colitis. Tiffany Taft, she's a psychologist at Northwestern. She's done a lot of fantastic work in this area. So in one study looking at PTSD in subjects with IBD and IBS, more patients with IBD met criteria for PTS than with patients with IBS. And IBD patients were more likely to attribute their PTS symptoms to their disease. So this was more the case with Crohn's disease than with ulcerative colitis, and was associated with more symptoms of heightened autonomic nervous system arousal. And hospitalization experience was thought to be the largest predictor of PTS symptoms in Crohn's disease. For ulcerative colitis and for IBS, symptom severity was predictor of PTS. So there was another study from the same group looking at factors that are associated with PTS and IBD patients and who've had a history of hospitalizations. So they sent out surveys to 639 adult patients with at least one hospitalization for IBD. 2/3 of patients had Crohn's disease. The majority of the patients were in remission. 6% had a self-reported diagnosis of IBD PTS. But they found that while the majority of patients, about 55%, reported their IBD symptoms were the cause of their source of trauma, 40% of patients stated that the hospitalization was that source of trauma, of PTS, and that frequent and uncontrolled anxiety during that hospitalization created risk for IBD PTS. So looking for potential interventions that could reduce this risk, the following 5 experiences were associated with more positive hospital experience. So feeling respected by nurses, being listened to by physicians, controlling pain, controlling anxiety. So the study points to the importance of improving that communication with patients, proper pain control, addressing anxieties, and all of this to try to reduce the risk of developing IBD PTS from the hospitalization itself. So the other important factor is that poor mental health and quality of life does not always coincide with disease activity. So this is a study that I participated in. It's for the Coravitas IBD registry, and we enrolled patients with Crohn's disease and ulcerative colitis throughout the United States. And we found that across the spectrum of disease activity, patients with IBD still experience significant impairments in patient-reported outcomes, fatigue, depression, anxiety, sleep disturbance, and pain interference. And so this speaks to the importance of going beyond treating the disease activity, but taking a more holistic approach to address the well-being of patients. So why is this so important? Because suboptimally treated mental health conditions in IBD can lead to increased disability, decreased quality of life, and poor medication adherence, more admissions and surgeries, and ultimately increased healthcare utilization. So patients feel this is important too. This is a survey that was administered to over 600 German patients that were given a survey about beliefs on complementary and alternative medicines. And they were asked the following questions. Is stress an important factor that influences the disease course? 70% said yes. And can effective coping with stress have a positive impact on disease course? 85% yes. So as physicians and caregivers, we have to pay attention to this. So let's shift gears a bit to better understand the biological basis of our brain-gut axis, inflammatory bowel disease. So who are the major players here? So it includes the autonomic nervous system. So this is composed of the parasympathetic nervous system and the sympathetic nervous system. There's the hypothalamic pituitary axis and the enteric nervous system. So this enteric nervous system can act independently, but also receives input from the autonomic nervous system and to affect motor functions, secretions, local blood flow, and endocrine functions. And then the combined effect of the autonomic nervous system and the HPA axis are really important for our adaptive response to stressors. So the autonomic nervous system is composed of the parasympathetic nervous system, and that's mediated by the vagus nerve and the sympathetic nervous system. So this vagal or parasympathetic activity is thought to give us anti-inflammatory effects, and therefore lower vagal tone can contribute to a heightened inflammatory state. So determine the balance between sympathetic and parasympathetic nervous system function. There are measurements of like heart rate variability that we can use, and it gives us an interplay, a dynamic idea of the interplay between those two. So in a chronic stress model, what happens? So you get high stress. This can lead to increased release of a corticotropin releasing factor from the brain. And this can go from the hypothalamus. This can lead to a dysregulated HPA axis response over time. And this leads to increases in pro-inflammatory effects in the gut. And there can be direct effects of the sympathetic nervous system from the brain and the adrenal glands to the gut. This leads to increased mast cell stimulation, increased intestinal permeability, and also could lead to increased changes in the microbiome. So microbes that thrive in a pro-inflammatory environment, they tend to propagate. They release more pro-inflammatory neurotransmitters that can lead to a more heightened inflammatory loop in these bacteria, then can cross the epithelial barrier, activate the mucosal immune response. And then lastly, we can have a decrease in vagal nerve efferents. So these are inputs from the brain that are supposed to be anti-inflammatory. So you get less of that. So that also, all of this can cause inflammation in the gut. So who are the major players? How do we measure the activities of the different players in our stress response? So we can measure brain activity using fMRI. So this measures changes associated with blood flow in the brain. I talked about autonomic nervous system testing using heart rate variability. So it measures the variations in time between heartbeats. And then you can also get a sense of the balance between the parasympathetic and the sympathetic nervous system this way. There's electrodermal activity. So this measures the sympathetic arousal. So it measures if there's sympathetic branch of your nervous system is stimulated, you get more sweat gland activity, and you get increase in skin conductance. So we can also measure gut microbes, stool and serum metabolites as well. And lastly, we can measure cortisol to better understand functioning of the HPA axis. So let's also talk a little bit more about the microbes. How do gut microbes communicate with the brain? So microbes interact with the immune cells in the gut, prompting the cells to make cytokines that circulate from the blood to the brain. And then microbes can also interact with cells in our gut called the enteroendocrine cells, and they produce neuroactive molecules and peptides. And these molecules can interact with the vagus nerve, and these send signals to the brain. And then the microbes in the gut can also produce neurotransmitters and metabolites like butyrate, and these circulate to the brain, where some of them are small enough to cross the blood-brain barrier, and some of them can alter cell activity at the barrier itself. So here's a table of some of the organisms in our gut that can produce various neurotransmitters that could potentially have an effect on behavior. GABA is thought to have neuroprotective effects and anti-inflammatory properties, and it's thought to enhance neuronal relaxation and potentially be protective against depression. So Bacteroides fragilis is an organism that's thought to be a GABA producer, and is thought to correct gut permeability, alter the gut microbial composition, and in a maternal immune activation mouse model, it was also thought to help ameliorate anxiety, anxiety-like behaviors. So bacteria can also exploit post-stress responses for enhancing its own growth and virulence. So E. coli, other proteobacteria, they can produce norepinephrine, but their growth can also be greatly enhanced by just physiological concentrations of norepinephrine. So with enterohemorrhagic E. coli 0157E7, the H7, the exogenous epinephrine is an inducer of the virulence factor for that. And then for enterohemorrhagic E. coli, in a stressed host, they tend to be more virulent than a non-stressed host. So now that we have some background on the important players in the brain-gut microbiome pathway, how is this relevant to IBD? Is there evidence to suggest that there is an important bidirectional signaling that occurs? So I'll highlight some examples in both animal models and in clinical studies to show this bidirectional relationship that it exists. So what happens in an animal model here? Can emotional conditions predispose individuals to IBD? So this is an animal model where mice are separated from their mothers for 3 hours a day at 1 to 21 days of age. So the controls are maternally unseparated mice. So maternal separation can lead to increased susceptibility to depression and impaired intestinal permeability. Interestingly, these mice don't develop colitis right away, but they do have an increased susceptibility to colitis. So if you give them an insult like dextran sodium sulfate in the maternally separated mice, their colitis is much more severe than in the non-separated mice. What's interesting is that this vulnerability is reversed by with antidepressants. So you give the maternally separated mice antidepressants, they have less depressive behavior. And interestingly, if you give them that same insult, the DSS, they actually have a decreased inflammatory response. So the antidepressants can actually make a difference. So this suggests that pre-existing depression can increase vulnerability to intestinal inflammation. So is there any evidence from population-based studies? So there are some studies that suggest this could be the case. So the Manitoba IBD population-based cohort, it included 351 patients, I think over 700 controls, and they evaluated lifetime prevalence of anxiety and depression as 32% and 25% for 32% for anxiety and 25% for depression in IBD individuals. And they found that that first onset of anxiety disorder was present more than 2 years before the IBD diagnosis in 64% of cases. And about half of those with the mood disorder experienced the first episode of depression more than 2 years before the onset of IBD. And then in another study that evaluated the incidence of IBD in patients with a new diagnosis of depression, they found that there was an increased incidence of Crohn's disease and ulcerative colitis than those without new depression. So interestingly, antidepressants were actually protective against the development of Crohn's disease and ulcerative colitis. So these studies suggest that mental health conditions can precede and potentially predispose individuals to IBD. So can stress and mental health conditions precipitate a relapse of IBD. So this is an interesting study where they looked at mice in which the colitis had been established and becomes quiescent. So it's a chronic colitis, but it's quieted down. And what they did was they produced a chemically induced depression by giving a mouse reserpine, or I guess they did bilateral olfactory bulbectomy. So that led to a depression in the mouse. And what that did, it inhibits then the protective effects that the vagal nerve is supposed to give. So vagal nerves can prevent pro-inflammatory cytokine secretion from macrophages. So it actually inhibits that when you induce a depression. And interestingly, if you administer a tricyclic antidepressant, it can restore the vagal function and reduce intestinal inflammation. So this study proves that there's some evidence around modulating this cholinergic anti-inflammatory pathway, that this can also precipitate or it can affect relapses of IBD. How about in animal models? Stress and mental health conditions, can they precipitate relapses of IBD? So in this study, the Manitoba IBD Registry, they looked at different factors that might be associated with symptom flares. They looked at NSAID use, they looked at antibiotics, infections, stress, and they found that 32% of patients had symptom flare over the year, but of all the factors that they measured, heightened perceived stress had the greatest impact of symptomatic flare over 1 year. And then in another study from the UK, they found this bidirectional association with mental health and IBD activity. So those patients that had baseline active IBD, this was associated with a 6-fold increased risk of later developing abnormal anxiety scores over the course of 2 years. And then those that had baseline quiescent IBD but had abnormal anxiety scores, this was associated with a later 2-fold increased risk of needing a glucocorticoid prescription or flare of IBD activity. So patients under the conditions of low perceived stress and who had effective coping strategies were least likely to relapse. So this suggests that these conditions are that mental health conditions are important and can affect the IBD course. In our study, we looked at 110 ulcerative colitis subjects in clinical remission, and we followed them out for over a year. And we found something similar. So we had found patients that had high perceived stress at baseline, they had higher percentage of relapse than in those that had low perceived stress at baseline. And so if we find that mental health conditions are important, if we have effective treatments for mental health conditions, can we improve the IBD course? So in animal studies, they found that if they give SNRI, venlafaxine, so Effexor, that decreased the exacerbation of acetic acid colitis in rats that were experimentally depressed. Amitriptyline, which is a tricyclic antidepressant, it reduced colitis without experimentally induced depression. And then amitriptyline also stimulated IL-10 production, which is an anti-inflammatory cytokine, and decreased inflammatory response to abdominal sepsis. So how about in clinical studies, do we see the same? So there's not as many good studies looking at the effect of antidepressants in IBD. In fact, there's no randomized controlled trials or prospective studies that really look at this, unfortunately. But there was a study, a Danish national database study, that suggested that relapse rates of IBD disease activity was lower among patients on antidepressants compared with non-users. So what about mindfulness-based programs? So mindfulness-based programs are focused on being aware of internal thoughts, feelings, emotions, and external surroundings and situations without automatic responses such as judgment or stress. And these are just some permutations of these types of programs. And in IBD, there's some studies that have suggested some benefit. In one study, they randomized patients to a mindfulness-based stress reduction program versus time and attention control. They had for 8 weeks a weekly session that was 2 to 2.5 hours, formal exercises and medications. And they found that while there was no real difference in the severity of flare-ups or the frequency of them in UC patients in remission, if they focused just on the subjects that had high perceived stress at baseline or high urinary cortisol at baseline, these patients did benefit. They had fewer flares post-treatment versus the controls. And then in another study where they looked at mindfulness-based interventions, they found that there was significant improvements of quality of life and decreases in anxiety right after the intervention. But then these improvements actually persisted at month 6, that they were maintained. There was decreased depression and improvement in quality of life even at that time. What about cognitive behavioral therapy in IBD? So the study has not been very strong for this for some reason. I think it has a lot to do with study design. So in this study, 179 patients with IBD in remission, they were randomized to standard care versus standard of care with CBT. And they conducted CBT over 10 sessions, either face-to-face or via a web-based program. They did not find significant differences between groups in IBD remission rates or in anxiety, depression, or coping at 12 months. And at 24 months, they didn't find that any significant differences either. And there was a high attrition rate, and I think they attribute that to the web-based group, likely due to that lack of a personalized approach. But what they did find, again, when we look at this, there was that extra group, that group with the patients that need extra support. So what is that patient population? They were pediatric transition care patients, patients with high baseline IBD activity despite being in remission, those that were diagnosed within the last year or had really high anxiety or depression scores or poor coping scores that they went in their tests. They found that CBT was associated with greater significant improvements in quality of life in that population. What about hypnotherapy in IBD? So there have been some interesting studies here. So there's one randomized controlled trial. Patients were randomized to 7 sessions of gut-directed hypnotherapy versus attention control, and they were followed for 1 year. And patients who received hypnotherapy remained clinically asymptomatic through week 52, and more so than those that did not have gut-directed hypnotherapy. And in patients that, in another study, they looked at 17 patients with active UC that underwent 50-minute gut-directed hypnotherapy. I find this interesting because there were actual physiological changes. They found decreases in heart rate. They also had decreases in pro-inflammatory cytokines that they could measure, reductions in rectal histamine as well. So we actually find there's physiological changes associated with hypnotherapy there. And then what is this acceptance and commitment therapy? I find this kind of interesting. So it's a little bit different than CBT. So acceptance and commitment therapy, it doesn't seek to eliminate or modify negative thoughts or feelings, but encourages an individual to accept these while simultaneously fostering commitment towards values that have been identified and adopted by the individual. So it uses training exercises to help individuals become more open and to develop more psychological flexibility. And with this therapy, they looked at patients with mild IBD with already pre-chosen elevated stress scores or low quality of life scores. 79 patients completed this study, and they were randomly assigned to 8 weeks of ACT versus control, and they found that 39% of patients that had ACT versus 8% in the control group had reductions in stress at week 8. And at week 20, 45% had reductions in stress versus 11% that were in the control group. ACT decreased perceived stress. It also decreased depression, but interestingly, it did not decrease anxiety. I think this is an interesting modality that we should explore further. What about randomized controlled trials with yoga and IBD? So there's only been 2 that I could find. One was looking at UC patients in remission. The other one did look at both UC and Crohn's disease patients. So in the UC study, patients were randomized to 90 minutes of yoga versus self-care. And they found that there was some decreased activity in the yoga group, not always statistically significant, but they did find significant group differences in a quality of life measure, IBDQ total score, favoring yoga over self-care. And in another study, they measured anxiety scores, and they found that patients that had yoga plus their medical therapy, that group versus the standard medical therapy group, they had significant decreases in state anxiety and trait anxiety when they had yoga in addition to their medical therapy. But there were no significant differences in clinical symptoms. So what does yoga and IBD do? So it's supposed to increase cerebral blood flow, increase neural activation, increase GABA levels. We talked about GABA earlier, increase prefrontal cortex activation, and that all is supposed to help decrease stress. And in the brain, it's supposed to help increase gray matter density in the hippocampus and maybe decrease that in the amygdala, and therefore decreasing perceived stress. So this was a study in this paper. I like this study from Kaur. They gave some practical suggestions of how we should administer the yoga. There was more benefit with a multimodal practice. So yoga postures with breathing and meditation, 5 days weekly for 6 weeks. And this dosing recommendation comes from studies in depression. In a randomized control study of 100 patients with depression and anxiety, they found that practicing yoga about 4.8 days a week for 29 minutes per session for 6 weeks was sufficient in improving depression and anxiety symptoms with a decrease in distress, increase in resilience, and this benefit remained for 7 weeks post-intervention. So now let's take a look at the other direction of the gut-brain relationship. So does intestinal inflammation influence the brain? So let's look at some animal and human data. So in this mouse model as well, so this is another colitis model, these mice that were subjected to this DNBS, they had increase in anxiety and depression-like behaviors, and they found in the brain that they had increased expression of genes related to inflammation in the hippocampus. And in another mouse model, when mice were injected with Campylobacter in the gut, they found that mice had anxiety and depression-like behaviors before the localized inflammatory response. So how about in clinical studies? So this is a study that looked at IBS and IBD patients, and they looked at they experienced anticipated and thermal pain stimuli on the forearm, and they had fMRI imaging. And they found that patients with IBD had higher activation in the brain perceptive regions during experienced pain compared to IBS patients. IBS patients had more activation in brain perceptive regions during anticipated pain. So it was a little bit different. And what they found also with IBD patients, they had deactivation of elements of this default mode network in the brain that's in charge of self-awareness, self-monitoring, self-referential processing. So in the study, they surmised that CBT could be helpful in downregulating pain experiences. So does IBD treatment actually affect the brain and behavior and perception? This is a really interesting study in 4 patients with Crohn's disease. So they had all undergone fMRI 1 day before anti-TNF therapy, a day after, and then 27 days after anti-TNF therapy. So first they did fMRI while they were tapping their finger. And then afterwards, they also had another fMRI with repeated abdominal compressions. And so what you can see here is that with finger tapping, you don't see much difference in the green in that fMRI activity from before anti-TNF day 1 and day 27. But in the red, with the abdominal compression, fMRI activity markedly reduced as early as 24 hours after anti-TNF therapy. So neutralization of TNF actually rapidly decreased pain perception in the brain, even before mucosal healing sets in. So I think that's fascinating. In another study looking at 160 patients with moderate to severe IBD receiving vedolizumab or anti-TNF therapy, they found meaningful improvement in sleep scores by week 6, and that persisted through week 54, and they found parallel reductions in depression and anxiety. So improvements of intestinal inflammation may have positive effects on the brain. So when we think about treating our patients with IBD, we often focus on treatments that are focused on intestinal inflammation. These are like biologics, surgery, immunomodulators, anti-inflammatory agents, but we have to be thinking about the whole patient. So we should be doing more screening, treating for depression, anxiety, identifying high stress reactivity early on, encouraging lifestyle adjustments to improve sleep, fatigue, and quality of life, maybe thinking about novel gut-brain axis interventions. So there may be some physiological metrics along this axis to help us self-regulate, including heart rate variability, the electrodermal activity I'd shown you. And then there may be some novel brain-gut therapeutics to also consider. So I think there needs to be more studies that look at adjunct antidepressive therapies. And then along the vagal nerve pathway, I think we should be thinking about some therapeutics along that line as well. Vagal nerve stimulation, we'll talk a little bit about. Microbial products may also be important for their direct effect on the intestinal barrier function and mood. So heart rate variability, it provides us with a non-invasive and quantitative measure of vagal nerve activity. And this RMSSD is a time domain measure, and it's thought to be free of respiratory variation. It's a good way for us to measure vagal nerve activity in some ways. So this can also allow us to evaluate parasympathetic nervous system responses. So this is a study looking at 34 children aged 12 to 18. They were followed for 12 months. And they had heart rate variability measurements. And they found that high baseline RMSSD was an independent predictor of lower risks of IBD exacerbation. So what that means is higher vagal tone at the very beginning. They're most likely they have lower risks of IBD exacerbation. Nowadays with wearable devices, we are getting information about heart rate variability. So I find that these kind of metrics may help us be able to self-regulate if we can see what's going on physiologically in our bodies. And this happens also with electrodermal activity. So this is, we can measure this continuously. The electrodermal activity is skin resistance changes with the state of our sweat glands. So with heightened sympathetic arousal, the sweat gland activity increases. There's increased electrical conduction as well. So in our study of 110 patients, we did measure electrodermal activity, and we found that those that had high perceived stress at baseline, they had higher electrodermal activity at baseline versus those that had low perceived stress. So could we use this if we measure it continuously to assess flare? would the electrodermal activity increase before a potential flare? And if that's the case, could we modulate, could we use biofeedback to kind of get ourselves back to kind of a different place? Could we try to lower that sympathetic activation, think about different cognitive, emotional, bodily attitudes, reset our physiological responses? I think this is something that would be really interesting with all the wearable devices that we have these days. Okay, so how about the ability to actually manipulate this brain-gut axis for IBD therapeutics? I thought this is like very sci-fi to me, but this is a vagal nerve stimulator. So it includes an implantable pulse generator that's put in the chest wall, and there's a lead that secures over to the left cervical vagus nerve, and it's tunneled to that pulse generator. And this study that was published last year, they looked at 16 patients with really biological drug refractory moderate to severe Crohn's disease, and they experienced vagal nerve stimulation once a week for 16 weeks, anywhere from 1 to 5 minutes up to 4 times a day. And they found significant decreases in the Crohn's disease activity index, so significant decreases in symptoms. And they found significant decreases in fecal calprotectin in those that had vagal nerve stimulation. Endoscopic improvement was a little more subtle, but it's possible these improvements would be more apparent later. So, but it's implantable, so it's kind of invasive, right? So there is a group that's looking at transcutaneous auricular vagus nerve stimulation. It's a proof of concept study here, where they looked at 22 kids, 10 to 21 years old, with mild to moderate Crohn's disease and ulcerative colitis with elevated calprotectin. And they randomized patients to this transauricular vagal nerve stimulator versus sham. They give them 5-minute duration, once a day stimulation. And they basically wanted to see, again, calprotectin changes in disease activity with the CDAI and the PUCAI. And they found actually some differences, decreases in calprotectin and Crohn's disease and ulcerative colitis disease activity indices. Very small study, but it's interesting. We might be seeing more about this later. So what about the microbiome? When we look at the microbiome, we could be using microbial profiling to determine patients who might be at higher risk for stress-associated flares. So in our study looking at ulcerative colitis patients, we found that there were some taxa that are associated with higher stress reactivity than lower. There were microbes belonging to the Ruminococcaceae and Lactospiraceae families. Large microbiome association studies also find associations between depression and members of these families. So my colleague, Jonathan Jacobs, he was able to put together a microbial index for stress reactivity using 8 taxa in this classifier. And what they found was that stress reactivity, stress reactivity microbial index, it was significantly associated with the risk of clinical flare at 1 year, adjusting for calprotectin and biologic use. Now, what happens when we look at plasma and fecal metabolites? So we also looked at these in our patients, at high versus low stress reactivity. And we found that high stress reactivity was associated with decreased endocannabinoids. These are basically all endocannabinoids. And in mice studies, we also see sort of similar patterns. You see reduced serum levels of monoacylglycerols as well. And they found that depressive behaviors and reduced serum monoacylglycerols could actually be transferred via the microbiome of stress-exposed mice. So depressive behaviors could also be reversed by pharmacologically increasing endocannabinoid signaling. So would alterations of the endocannabinoid system affect our central stress response in IBD? I think these are interesting questions that we should explore. So to kind of finish up, I wanted to just touch upon some preliminary studies looking at virtual reality. I thought this was really interesting to deliver mindfulness-based therapies to children with IBD. So this is a small study from Stanford, and they looked at 62 children and young adults with IBD that had 6 minutes of mindfulness virtual reality intervention. And kids completed a pre and post intervention survey. And so with preliminary analyses, there was improvement in anxiety, improvement in pain, and children expressed their interest in using VR in IBD medical settings during hospitalizations, IBD procedures, and IBD treatments. So we'll probably be seeing a little bit more about virtual reality for IBD in the future. So let's talk a little bit about mental health support. How much is there? Are we doing a good job? Spanish cohort of 903 patients and 170 physicians. In this study, 28% of patients reported that their perception that gastroenterologists were not interested in their mental health. And roughly a third of physicians reported that they didn't feel qualified to detect psychological problems. And 50% of physicians that said that they inquired routinely about psychological functioning, but patients reported it only happened about 25% of the time. And I think this is, kind of indicative of what we probably are seeing in the clinics. There's not a lot of time and resources to be able to support mental health. And I find it a real challenge. And I think something that we need to really address and figure out how to address better in our care for our IBD patients. So I love this idea of an IBD medical home. So it's a fully integrated gastropsychology model. Includes a mental health professional, health psychologist, includes social worker that has some therapy background as well, all located at the IBD center. And in this way, care coordination can happen all together with the patients all in the same place. At Mount Sinai, they have a nice model called the GRIT IBD. That's a good model of this. And I think this model has been shown to also decrease healthcare utilization as well. So I would love this type of model to be available, but I think it's something that requires some resources, and I think this is what's necessary. In addition to focusing on the intestinal health and getting mucosal healing, we have to really focus on psychological healing. So I hope I've convinced you today that there is some bidirectional relationship between the brain and the gut, and that this relationship is very important for IBD. And I hope we realize the importance of not only mucosal healing in IBD, but also psychological healing in IBD. So we do need more high quality data to assess psychological and behavioral interventions that focus on improving quality of life. That's just as important to me than the actual mucosal healing itself. We have to also focus on quality of life. And I do think that IBD programs, we do need broader mental health support. And I'm hoping programs like yours that you're going to start, this IBD restorative program, can help provide this important wellness factor that we need, that sometimes we're lacking in our clinics. So with that, I'm going to open up to questions. Thank you for the opportunity to speak. And I'd love a discussion after this.